this is a lecture we will record. It will be on the Global ENT website. And again, I'd like to present Dr. Ray Kung, USC School of Medicine, Clinical Assistant Professor. So Ray, thank you very much for joining us. And we're ready to hear all the great words of wisdom that you have to offer us.
Great, thanks Richard for the introduction, and thanks for inviting me here. This is an honor to be able to speak here. So this is going to be based on the Bailey's textbook chapter called Diseases of External Ear that I recently submitted in December. So eventually, once that newest edition of Bailey's comes out for otolaryngology and surgery, you may be able to see that chapter as well. So this is just distilled version. Just to start with, since I thought this was helpful for me, when examining the ear canal is oriented initially going posteriorly and superiorly. And that's why when we examine, it's best to do what is some people call a chin tuck to the opposite side. So that chin tuck is a combination of adequate rotation versus this is under rotated, and a little bit of neck flexion as opposed to neck extension. And then also it's important to make sure the head is not tilted in the plane. And this is from the Stanford Otologic Surgery Atlas, which you can find online for free, which is a great resource. And this shows that you'd want to have a shoulder roll for children because of their bigger head ratio versus a donut or blanket under the head for adults in order to get rid of that tilt to help with your examination in clinic or in surgery. Just a brief overview of the sensory innervation. It's complex with external ear. It involves cranial nerve 10, specifically the auricular branch, and that's also known as the Arnold's nerve, which is responsible for rare cases of auricular syncope, or essentially a vasovagal response, just from instrumenting the ear, putting a speculum in. One of the reasons some people say always examine the patient supine in case that happens. Other nerves, you have the cranial nerve 9, the Jacobson's branch of 9, or branch of Jacob's nerve that innervates the internal surface of the TM. You've got cranial nerve V3, you've got cranial nerve 7, and also branches of C2 and C3, the lesser occipital and great auricular nerves. Okay, on to the diseases. So common things being common, acute otitis externa is the most common thing that we see. And the most important takeaway from this lecture is to really be thinking about all the other potential diagnoses that could be underlying an acute otitis externa. So as we know, acute OE is rapid onset in general. You have pain and drainage of the ear. This is a normal ear canal. This is a patient with acute OE with obstruction of the external auditory meatus from a zoomed out view of the lateral canal. And then this is in the canal itself. You see edema, erythema, debris. And this is an otomycosis version with some fungal elements. So usually this is a mixed bacterial origin with Pseudomonas aeruginosa and Staphylococcus aureus. Fungal is uncommon in primary acute OE. It's more likely as a superimposed infection from chronic otitis externa or secondary to drops. So treatment, as we know, is debridement to remove all the, to get a good surface for your topical antibiotics to act in the tissue. In general, no culture is needed if it's an uncomplicated acute OE. A wick can be placed if there's obstruction. It's important to get the wick to the correct depth. I've seen a case where the wick wasn't deep enough and just need to be a few millimeters deeper to open up that obstructed medial part of the ear canal. And also always think about alternative diagnoses or underlying pathologies that acute otitis externa can be presenting on top of. The general guideline, clinical practice guideline, is that we shouldn't be using systemic antibiotics for an uncomplicated acute otitis externa initially. So as long as they're not immunocompromised or have a history of diabetes, as long as they don't have extension into beyond just the external ear or just beyond the ear canal, then we shouldn't be using oral antibiotics initially. So for topical treatment, there are many different kinds, and there were 3 meta-analyses that found there's no difference between whether you use antibiotics versus antiseptic, if you use quinolone versus non-quinolone antibiotic, or if you're using steroids without steroids. So some examples that we commonly use are Ciprodex or ciprofloxacin plus dexamethasone, ofloxacin, combination of neomycin, polymyxin, hydrocortisone, acetic acid by itself or with hydrocortisone, and other things that have been effective on their own, boric acid, aluminum acetate. Boric acid is also your ant and roach killer, so you can just get that over the counter. Silver nitrate, dental violet, steroids. Steroids alone have been effective for acute otitis externa. Also combination powders like CSF powders are really commonly used, combination of chloramphenicol, sulfonylurea, sulfonamide, which are antibiotics, and then also fungizone, which is the amphotericin antifungal. If there's a perforation, that's important to know, and you'd want to, if you can't tell, then you'd want to do a Temponometry or pneumatic otoscopy to figure out what's safe to put in the ear. Because you want to avoid alcohol, vinegar, and aminoglycosides because of ototoxicity if it gets into the middle ear, as opposed to fluoroquinolones being safe for the middle ear. If a patient has complicated acute otitis externa, then they may need systemic oral antibiotics, and that could be fluoroquinolones like ciprofloxacin, penicillin, cephalosporins, aminoglycosides. You may need to culture them, and if it's really severe, they may need IV antibiotics. So a variant of acute otitis externa is furunculosis, which is essentially just a pimple, starts off as an obstructed hair follicle that becomes a pustule and enlarges into a furuncle, and then multiple furuncles can merge to become a carbuncle. And you may need to do an incision and drainage, or you can, with or without the drainage, and topical oral antibiotics. So chronic otitis externa, another commonly seen disease of the external ear, it's predominantly itching. They, on exam, would have dry, flaky skin. Duration is usually more chronic, greater than 6 weeks, and they may have a history of dermatologic disease. This predisposes patients to recurrent acute otitis externa because they're always itching and scratching, causing trauma. And rarely this can lead to acquired ear canal stenosis, which we'll talk about. So the treatment is, as we know, debridement and use of topical steroids, for example, triamcinolone, betamethasone, fluocinolone, dexamethasone, what have you. And you can also try adding nystatin because sometimes there's fungal to otitis externa. So interesting to note is that aminoglycosides actually cause a contact dermatitis, or allergic contact dermatitis in patients with chronic otitis externa. Another treatment is use of half-strength vinegar or ethanol. And prevention can be done by keeping the ear dry, using custom ear molds, earplugs, even drying powders. And if the patient is not improving with all the above, then think about otomycosis, because sometimes you don't have the classic fungal elements on exam. Chronic eczematous otitis externa is specifically referring to essentially a broad category of dermatoses of the external ear. So here's some of the subtypes. Eczema, which is an atopy or atopic dermatitis. And again, you have the same red, dry, scaly skin. You can have some lichenification, hyperpigmentation, and the treatment is like you would treat an eczema of any other part of the body with skincare, emollients, topical steroids. Seborrheic dermatitis is caused by the yeast Malassezia, and you'd have these greasy, yellowish appearing scales and would be treated with the topical antifungals, anti-inflammatories. Contact dermatitis can be broken down into two main kinds. Irritant contact dermatitis, which is just from direct dose-dependent exposure to acids or alkalis in general that everyone is susceptible to. Then there's the allergic type, which are in atopic individuals. Most common cause is nickel. You can also have silver that causes this allergic chronic contact dermatitis. Chemicals like cosmetics, soaps, detergents, shampoos, hairspray, plastics, silicone, acrylics, and hearing aid molds, rubber, leather, and even medications like we learned about earlier, aminoglycosides, sometimes even certain steroids, triamcinolone, hydrocortisone can even cause contact dermatitis. So you really have to think about, well, if this is patient's just not doing well, despite everything you tried, maybe try taking away certain medications. And this contact dermatitis is a delayed type 4 hypersensitivity, which requires a sensitization phase of about 2 weeks. So treatment is to get rid of the offending agent, use topical steroids, topical anti-inflammatories. You can even get fancy with calcineurin inhibitors like tacrolimus, which is also called Prograf, or pimecrolimus. And psoriasis and lupus can also present with chronic otitis externa. You would treat the same way that you would treat the psoriasis, and you use the same medication that the dermatologist is giving them for other parts of their body. So acquired ear canal stenosis, this is rare, less than one in 100,000 cases. It's also called post-inflammatory medial canal fibrosis. So it starts in the medial ear canal, also called chronic stenosing otitis externa or obliterative otitis externa. And it's most commonly due to chronic infection, so chronic otitis externa or a chronic granular miringitis. It can also be caused from inflammation, trauma, radiation, prior ear surgery. So generally this starts off as a cycle of deepithelialization of the lateral surface of the TM or medial ear canal that then forms granulation that degenerates into a fibrosis, fibrotic tissue, and that's considered the wet phase when it's chronically draining. And eventually that plug can work its way all the way to the fibrosis can build up all the way to the bony cartilaginous junction as seen on the CT here. And that's when it burns, quote unquote, burns out and becomes this dry phase. And at that point, you would consider doing a resection, surgical resection of the tissue with canalplasty, possibly widening the bone, and with or without a meataloplasty, and lining it with a split thickness skin graft, with the most concerning complication of being restenosis. Prevention of getting to that stage, you can try topical antibiotic steroids just like you're treating your chronic infection. And the powder form is favored because of the consistent drug levels that are being delivered to the tissue. Wicks can be placed because it's being obstructed, but that may accelerate disease because you've got this foreign body there that keeps inflammation going. Malignant otitis externa, I'm going to spend a good chunk of the lecture talking about because it is a potentially life-threatening complication of an otitis externa in general. And it's complex. It's a challenging disease because it lacks really clear diagnostic criteria, doesn't have great prognosticators, and we don't have well-established guidelines for treatment. Malignant otitis externa, it's a bit of a misnomer because it's not actually malignant. There's no neoplasm, so people have called it necrotizing otitis externa to try and change that. But the more accurate term is probably skull-base osteomyelitis. Unfortunately, the name hasn't really caught on as well. And in the literature, you still see the term malignant otitis externa. So for the sake of the lecture and ease, I'll just call it malignant otitis externa, or MOE for short. So MOE starts as an acute otitis externa that spreads outside the ear canal through multiple pathways. So fissures of Santorini, the bony cartilaginous junction, or if patients have a persistent foramen of Huschka. Then the infection can spread along the tympanomastoid suture and soft tissue. It will respect fascial planes as opposed to malignancy, which doesn't. Most frequently, this will spread to temporal bone, but has a rather unpredictable pattern of spread. So the tissue, the infection, then once it gets to the bone, becomes an osteomyelitis, where the bone vasculature is infiltrated, and impaired flow causes necrotic bony sequestra to form with a surrounding area of new bone growth. So this would be indicating the fissures of Santorini, which are natural openings in the anterior lateral ear canal cartilage. And you would be going into the parotid and masseteric space. Here's your bony cartilaginous junction. The foramen of Hrushka remains persistent in up to 46% of the population. And it's an incomplete fusion of the anterior medial inferior bony ear canal. And this would go into your TMJ, your peripheral space, and temporal fossa. So this is a busy slide, but it's just to point out the possible spaces of spread of MOE. So you have connection to the parotid space, and masseteric space, temporal fossa, connection to the infratemporal fossa, peripheral space, nasopharynx, preclival space, the prevertebral space, and also intracranial to the middle and posterior cranial fossa. The rest of the contents of those spaces I'm not going to go through. So patients will present with persistent otalgia and otorrhea, which are obviously non-specific and can be misdiagnosed as just an acute otitis externa. But the most important diagnostic criterion is lack of response to initial therapy. And patients tend to be elderly, diabetic, and or immunocompromised. On exam, a more specific finding would be on exam seeing granulation tissue or polyp at the bony cartilaginous junction, and that's arising from an underlying osteitis. Another specific finding is cranial nerve involvement, which can occur in up to 46% of patients. Cranial nerve 7 being the most common just because of its proximity. Cranial nerves 9 through 12 can also be involved. Some people will scope patients just to check their vocal cord mobility. Predictors of advanced disease in general are if there's any cranial nerve palsy, there's signs of vascular thrombosis, vascular involvement, and or intracranial extension. The current mortality rate is reported at about 15 to 30%. It was higher in the past. So feel free to stop me if you have any questions. So the offending pathogen used to be exclusively Pseudomonas. Recently, that has Pseudomonas has really dropped to as low as 25 to 50% of patients, and instead we're increasingly seeing Cipro-resistant Pseudomonas, as well as non-pseudomonal organisms like invasive fungi or MRSA. And both of these are associated with prolonged treatment, higher morbidity. And it's thought maybe it's because patients are getting misdiagnosed and they're getting treated inappropriately with the wrong antibiotics, antimicrobials. Another thing to be thinking about is if patient has HIV or immunosuppression, fungal malignant otitis externa can be the cause, and most commonly Aspergillus Merigitis. So diagnosis is challenging for MOE because the findings are nonspecific. Patients generally don't have really severe infections, kind of a smoldering chronic thing. And instead, diagnosis is based on just looking at the big picture as a whole of the history, plus the exam, plus the labs, the culture, biopsy, and imaging. And again, the non-responsiveness to therapy, to initial therapy, is probably one of the most important diagnostic criteria. Your labs, your ESR is always going to be elevated. CRP is going to be elevated in most. And it's uncommon, however, to have a high white count or neutrophilia or fever, which again makes it hard to diagnose. Cultures, ideally you want to get cultures of the ear canal before starting any antibiotics. And some would even argue that any kind of acute otitis externa that is out of the ordinary, older patient, immunocompromised, anything that just seems a little bit more advanced or beyond the ear canal, you might want to culture it before you start putting the antibiotic drops. Otherwise, you'll have negative cultures once you start the antibiotic drops, and then you may end up being forced to do a deep open culture, deep biopsy. If you see any mass, you want to biopsy to rule out malignancy, because this can also masquerade as MOE. The TM and middle ear are usually not involved, but if it is involved, then you want to be thinking about malignancy. So imaging, there is no best single imaging modality for both diagnosis and for monitoring with follow-up. Initially, most people will get a CT scan, and that's great for bony detail. Problem is that the bone destruction usually doesn't occur until late stage or advanced stage MOE. So if you have an early MOE patient, you might be missing something. A CT can, however, clue you into any soft tissue extension beyond the ear canal that may clue you into a more advanced otitis externa. MRI, however, is superior compared to CT for soft tissue definition, especially when looking at intracranial disease and looking at bone marrow. So on T1 weighted MRI, you would see dark signal hypointensity for any inflamed normal fat. So if you've got loss of your normal fat planes and your fatty bone marrow, which should be bright on T1, they would be dark if there's inflammation there. Your T2 would be dark also in the same areas if there's inflamed fat, because you get localized compromise of blood flow. And also you'd have signal voids or flow voids that can indicate thrombosis. And that can be confirmed by MRA and MRV, though that's not your standard initial protocol, that those can help with confirming any suspected thrombosis, which is, as we said before, an advanced sign of disease. So T1 with contrast gadolinium would be bright and light up involved fatty bone marrow, involved soft tissue, dura, intracranial tissue. And we want to ideally do that with fat suppression to differentiate it from just normal bright fat. Diffusion weighted imaging can be helpful to identify lymphoma, nasopharyngeal carcinoma, abscess, cholesteatoma. And MRIs are good for follow-up for soft tissue, but not good for a bone marrow, because your bone marrow signal can persist for up to a year. Okay, so nuclear imaging, also called functional imaging, these are seeing what's actually functioning with the bone, the white blood cells, the osteoblast, can be useful for diagnosis and monitoring. So technetium 99 is one that we tend to start with first, because it's very sensitive. It's good for diagnosis. It's not good for follow-up, however. It's very sensitive. It can detect as little as a 10% increase in osteoblastic activity. It's very cheap in general, it's available, and it's positive in early disease. The problem is it's not very specific, because you can have any sort of trauma, inflammation that can increase your osteoblastic activity and light up. And the other problem is that it can remain positive for a long time, because a bone is going to continue to remodel for years. And so that slight increase in that activity will continue to be bright. So it's not good for monitoring and follow-up. Gallium-67 and indium-111, they are good for both diagnosis and monitoring, because their signals will resolve upon resolution of the disease. But they're time-consuming, they're expensive, and have a higher radiation burden. FDG PET, you think of your PET scans, you can combine that with MRI and CT, MRI or CT. That's good for both diagnosis and monitoring, just like gallium and indium-111 scan. And FDG, which is the fluorodeoxyglucose used in your PET scans, it's widely available, and you get less radiation than gallium-67. So if you're doing a technetium, gallium, or indium scan, you would want to combine that with SPECT imaging to get better anatomic resolution, because otherwise you have poor resolution. So what are your options for imaging for MOE in general? You probably already have a CT scan, and if there's some soft tissue inflammation, that may clue you in. Sometimes we get an MRI if we're a little bit suspicious, and if the MRI is even more suspicious of bone marrow involvement, then that may help us pull the trigger on getting the technetium. Or if it's really clear on the exam, we have high suspicion, then we may just jump straight to the technetium without getting an MRI. And so you can do both a technetium initially with a gallium and then follow up with a gallium or indium. Another option some authors like to do is doing a PET MRI initially and for follow-up diagnosis. Or if MRI is contraindicated, not available, then PET-CT. The problem is it really it does take time to do these PET MRIs and PET-CTs, and it takes up that scanner time. So this is a general overview of comparison of these imaging modalities. CT scan is great for bone definition, whereas all the others are not. And for your nuclear imaging or your functional imaging, the highlight for them, they're great at detecting bone marrow involvement. MRI is okay at looking at bone marrow, but it's just not nearly as great as or sensitive as your technetium, which is evaluating the osteoblast activity versus gallium and indium, which look at white blood cell activity, and your PET scan, which is your FDG uptake. Soft tissue definition is so-so on CT. It's better with MRI. It's poor with your technetium, gallium, indium, and then your CT, PET MRI are going to mirror your CT and MRI. Spatial resolution is great for your CT and MRI, but if you're doing a technetium, gallium, indium, as I said before, you would need to do that SPECT imaging to get good anatomic resolution. Follow-up is not great with CT nor MRI. MRI, because that bone marrow will stay bright even after disease resolution, and same with technetium, even longer, so even more so, it'll stay bright. But you have good resolution of the signal with disease resolution when you do your gallium, indium, and your PET FDG scans. So this is an example of a patient with MOE, and the CT scan is pointing to inflammation of the soft tissue area, the TMJ, the parapharyngeal area. You've also got some bony erosion in the bone window. You have the anterior medial ear canal and some soft tissue filling the ear canal. This example of another patient with bone erosion on the CT, some soft tissue enhancement of the stylomastoid fat pad here compared to your uninvolved side. And then this is the MRI showing T2 without contrast. Normal side is bright, normal fat. And here is involved, dark, hypointense fat at the stylomastoid foramen area. And here's T1 with gadolinium. You see it's lighting up in that involved area. This is a patient with gallium scan that shows MOE on the right side here. And here it is fused with SPECT imaging to give you that spatial resolution. So how do we treat MOE? If they have diabetes, then meticulous blood glucose control. We want to debride any necrotic tissue. You want to do culture-directed antibiotics for at least 6 weeks. The length of treatment is a bit controversial, but theoretically, it takes 3 to 4 weeks for bone to revascularize. So that's why we want to do at least 6 weeks or so. So back in the 1980s, oral ciprofloxacin by itself became first line. It really revolutionized the treatment of malignant otitis externa, decreased the need for surgery, and it was great. However, then we developed ciprofloxacin resistant Pseudomonas, in the 1990s. And it's thought to be maybe because of the overuse of Cipro and fluoroquinolones as a medical field, and particularly with antibiotic ear drops. So now it is thought that Cipro monotherapy by itself is not adequate, not going to work for about a third of your patients that have MOE. And instead, it's recommended to do at least 2 different antibiotics with double coverage. So for example, Cipro plus another anti-pseudomonal like ceftazidime. If patients have advanced MOE, then you want to consider broad spectrum coverage with inclusion of vancomycin, and or cefepime, ceftazidime, meropenem. If they have any intracranial abscess, you want to add flagyl, metronidazole. If they have HIV or immunosuppression and they're failing therapy, then you want to think about fungal MOE, which should be treated with amphotericin B, which the liposomal form is less toxic, or your azole, so itraconazole, fluoroconazole, or caspofungin. Now, surgery, it's unclear, it's still controversial what the role of surgery is. It's obvious if you have an abscess, it needs to be drained, but sort of relative indications are patients are having progressive or persistent symptoms, persistent granulation. If they start developing worsening signs like cranial neuropathy, despite being on top of your medications. And surgery would be for either deep tissue biopsy of any masses. Or culture to identify any drug-resistant Pseudomonas or non-Pseudomonas like invasive fungi, MRSA. And the surgery can range from just excision of the ear canal with maybe needleplasty to doing a subtotal temporal bone resection or wide resection requiring vascularized tissue flap, or just doing a cortical mastectomy to do sampling. Hyperbaric oxygen is theoretically going to help with diseased bone by facilitating osteogenesis for advanced disease. But it's expensive, it's not convenient, it's limited, and there isn't great evidence to support it. So over time, MOE has really changed. I think it's part of it adds to the difficulty of treating this. In the 60s, when this was recognized as a clinical entity and called MOE, this was primarily Pseudomonas, and we didn't have any Cipro yet, or didn't figure out that would work, and it was treated primarily as surgery, rather high mortality morbidity rate, and required multiple drugs, IV administration, and high toxicity. Patients were always elderly and diabetic, mostly elderly and diabetic. Then in the 80s, 90s, we started, we were really revolutionized by anti-pseudomonal antibiotics. And there was less surgery, it was more for really bad cases. Monotherapy with Cipro was working well, and so patients didn't really need IV antibiotics as often, and they could be treated on an outpatient basis. And we're starting to see some younger immunocompromised patients. And more recently, we are seeing the drug-resistant Pseudomonas. We're seeing non-pseudomonal pathogens like fungi, MRSA, and surgery is being increasingly advocated for culture and biopsy to identify these. We are seeing Cipro resistance probably because of the just ubiquitous use of fluoroquinolones in medicine as a field. Now we're kind of swinging back to the need for multiple drugs, possibly IV, and more extended hospital stays. And these elderly diabetic patients are making up less of the proportion. In general, the morbidity is higher than your Cipro-sensitive Pseudomonas, possibly due to the delay in identification. Okay, so otomycosis, on to the next topic, is a fungal otitis externa. It's usually superimposed on chronic OE. and is secondary to prolonged usage of antibiotic drops, changing the flora of the ear canal. Aspergillus is the most common, usually Aspergillus niger. If you're seeing Merigitis or flavus, then you want to think about it, well, this may be an invasive form, which they're rare, but you can have invasive fungal otitis externa, which could require itraconazole, voriconazole, amphotericin, caspofungin. Treatment of otomycosis in general is debridement, acidification, drying powders, boric acid again, and your combination CSF powders, clotrimazole, nystatin, gentian violet. So viral infections, herpes zoster oticus being the most important one for us, also called Ramsay-Hunt syndrome. It's a reactivation of the varicella zoster virus that's dormant in the geniculate ganglia of cranial nerve 7. It's rare. This is a double-stranded DNA of the human herpes virus family, and patients will get have a history of a primary varicella zoster's infection, also called chickenpox, which is a disseminated vesicular rash with fever that then lays dormant in cranial nerves and dorsal root ganglia and reactivates decades later. Patients have the triad of facial paralysis, otalgia, and vesicles of the external ear. They can also have vesicles of the oral cavity. Patients can start with a prodrome, fever, fatigue, pain, burning sensations of the ear and face. And then vesicles usually start a few days later. Those that can rupture and crust a few more days later. And you can have this persistent rash for a couple of weeks, or erythematous macular rash. Patients can also lose taste to the anterior 2/3 of the tongue from choroid tympani involvement, hyperacusis, and also decreased lacrimation. Cranial nerve 8 can be involved, leading to hearing loss, tinnitus, and vertigo. And it's recommended to urgently treat patients with antivirals and steroids to reduce the risk of long-term facial palsy, and as well as post-herpetic neuralgia, those two being the most concerning issues or long-term complications. Facial paralysis can resolve in 27 to 70% of cases if these antivirals and steroids are started ideally within the first 72 hours of symptom onset. Otherwise, you have a slightly less chance of facial paralysis resolution. So the course length can be 7 to 10 days. Some people even say up to 21 days for acyclovir, famciclovir, valacyclovir, ganciclovir as examples. ENOG, or electroneuronography, is for patients with complete paralysis, because if they have complete paralysis, then there's a potential role for facial nerve decompression, but that's debatable. Especially because herpes virus tends to have skip lesions and involve multiple areas of the facial nerve. So are you really going to do like an entire facial nerve decompression? More severe symptoms and older age portends a worse prognosis. And in general, when it comes to facial paralysis, patients have worse prognosis compared to Bell's. So more than half of patients develop post-herpetic neuralgia, which can be rather debilitating and can persist for greater than 3 months. Perichondritis is an infection or inflammation of the ear cartilage due to trauma or an acute otitis externa that has gone awry. Patients have pain, swelling, erythema, abnormal contouring of the ear, weeping, crusting. But the fatty lobule, which is not cartilaginous, is spared. Patients have bilateral or recurrent perichondritis and think about relapsing polychondritis. This needs to be treated aggressively to prevent development of a subperichondrial abscess with resulting ischemic cartilage necrosis, which can lead to cauliflower ear deformity. So we treat with debridement, topical and oral anti-pseudomonals. You may need IV antibiotics because established infection is very challenging to deal with of the cartilage because of the poor blood supply and the low metabolic demand of cartilage. In severe cases, you may need to debride surgically in the operating room, ideally, because necrotic cartilage tends to extend further than what we think. It's a bit of a tip of the iceberg idea. And you would be looking for that loss of the normal pearly white appearance of cartilage. And you probably would want to put some small drains afterwards. So relapsing polychondritis, it is rare and it's difficult to diagnose, partly because it's rare, it's a widely variable presentation, and there are many systems involved, and about a third of the patients also have other autoimmune diseases. It is an episodic progressive autoimmune destruction of fibroelastic cartilage, with the ear being the most common. The nose, in about a quarter of patients at the time of diagnosis, which can lead to saddle nose deformity we're seeing here. Respiratory chondritis can be devastating with laryngeal collapse, strictures, mucosal edema, webbing. You can end up with fatal airway obstruction that requires trach or airway stenting. Symptoms for relapsing polychondritis are episodic, so episodic fever, anemia, red, pain, swelling, cartilage. And you can get elevated ESR, IgG, antibodies to collagen. Treatment is with anti-inflammatories, immunosuppressants, things like dapsone and colchicine, and if it's really severe, steroids. And obviously rheumatology consult. So Merigitis is relatively rare, and it is an inflammatory disease of the lateral surface of the tympanic membrane, and sometimes a medial ear canal skin that's adjacent to that. It's characterized by de-epithelialization as well as granulation. And the most common forms we see are granular miringitis, which is a chronic form, and then also bullous miringitis, which is an acute form. So to kind of highlight the differences, again, chronic is your granular miringitis, bullous is more acute and associated with otitis media, or it can be isolated, and it's classically thought to be viral, but it can be caused by mycoplasma, as well as strep, Haemophilus. And usually bullous is more severe pain, and granular miringitis is less pain with, and you can have odory in both, especially if the vesicles rupture, then it can be serous vesicle, or it can be hemorrhagic. And the interesting thing about bullous miringitis is that you can get this sensory neural hearing loss that in rare cases it can persist. It's not understood why that happens, but it is recommended to get an audiogram for all patients that have bullous miringitis. Treatment is the same as an otitis media plus an otitis externa with drops, but you may need some more analgesics because it could be pretty severe pain. Granular miringitis, that you would see this granulation tissue on the TM. You may have some conductive loss, but it can be normal. This can rarely progress to a medial canal fibrosis. So you imagine you just keep getting inflammation of this area, then you can get this degeneration into fibrotic tissue. The treatment is a combination, ideally a combination of debridement and topical therapy, rather than just topical therapy alone, according to studies. Also, you can use some dilute vinegar irrigation, which tends to work potentially better than your antibiotics and steroids, according to a couple of studies. Right, keratosis obturans versus Canal Klesatoma. This was thought of as a single entity, same thing in the past, but now it's separated, and it's generally believed to be two separate entities. But there's lots of overlap, and there's really no great way to distinguish the two. The most reliable distinguishing things are that Canal Klesatoma is a localized periosteitis with localized osteonecrosis and a focal ulcer of the ear canal skin, whereas keratosis obturans it's more of a circumferential involvement of the skin. The skin is actually intact. There's no necrotic bone, and keratosis obturans is actually thought to be from abnormal epithelial migration. So you don't have the normal conveyor belt system of the ear canal cleaning out that keratin, or it may be because of hyperplasia of the ear canal skin that's producing too much keratin. But really, it's poorly understood why we get either of these. And keratosis obturans in general, they have more pain and it's more acute versus the chronic and dull pain and canal cholesteatomas. But as we'll see, you can have silent keratosis obturans. So these are really not established differences. There's lots of overlap. And canal cholesteatoma, you frequently have more otorrhea, more normal hearing. It's usually unilateral as opposed to bilateral, and it's in older patients. So here is an example of keratosis obturans. This is a keratinaceous squamous epidermal matrix that is tightly adherent to usually the medial ear canal, and you can have a widened medial ear canal, which leads to an automastoidectomy appearance. And this is an example of a silent keratosis obturans patient before removal. This is after removal, which actually shows an automastoidectomy back here and actually an exposed facial nerve, so very rare. We would treat the underlying inflammation with topical drops, vinegar and or hydrogen peroxide. Irrigations can routinely help reduce the buildup of keratosis obturans, but patients often need lifelong debridement so that this doesn't progress. Canal cholesteatoma is, like we said before, it's an invasion of the squamous epithelium into a focal area of periosteitis with a characteristic osteonecrosis and a local focal ulcer of the skin. It's rare compared to your middle ear cholesteatomas, and here's an example of that invasion into the bone. You can break this down into primary and secondary cholesteatomas. So primary, it can be spontaneous, it can be congenital, like in this patient who has a microtia plus a canal atresia and trapped epidermis. That's really eroding into the bone here. She required an endoral approach to an atresioplasty and removal of this. Secondary causes, there are many. It can be from a prior surgery, which I've also seen, post-traumatic from a temporal bone fracture. It can be from, and I've seen that as well, from an injury of the jawbone getting shoved into the ear canal and causing a trauma that way. And many years later, the patient then started developing signs of cholesteatoma. Post-obstructive from obstruction of the meatus, for example, osteomas or exostoses, and I've seen a case of that as well. Foreign bodies. Post-inflammatory, so from chronic otitis externa, can lead to canal cholesteatoma. So some surgeons recommend doing a removal of all canal cholesteatomas you encounter, as well as the underlying necrotic one, to prevent any worsening. But some others say that you can watch small cholesteatoma. You can really just keep cleaning them out and then operate only if erosion progresses. And so I have one patient that we're continuing to just debride, and is actually doing well with debridements. And even though there was initially a focal necrotic bone area, that has started to really close on itself. And so I think we can get away with just debridements. Surgery is certainly indicated if there's erosion, excuse me, into the middle ear, into the mastoid, facial nerves, the labyrinth, or if patients are really symptomatic and unresponsive to just conservative debridements. And surgery would entail canaloplasty with removal of cholesteatoma and bony sequestra until you get to healthy bone. And then you'd want to line the canal with connective tissue which can take several weeks to re-epithelialize. So exostoses versus osteoma. Exostoses is thought to be caused due to cold, wind, and water exposure, surfing, surfer's ear, versus osteoma is not related to that. Exostoses are sessile, broad-based, whereas osteoma has a very narrow base, and sometimes you can just chip off an osteoma and be done. Location is usually it can be anywhere, but initially it starts in the medial canal for exostoses, anterior superior area. Osteomas are more laterally. Exostoses, the pathology is an underlying chronic periosteitis from the cold exposure, versus osteoma is actually neoplastic, benign. Exostoses are usually, you have multiple versus solitary osteoma. Exostoses are usually bilateral, osteoma is unilateral, which makes sense with being neoplastic. And exostoses on histology, you see dense lamella within the bone versus a cancellous bone fibrovascular channels for osteoma. So here's an example of an exostoses. There's a grading system. Normal, this is grade 1, which is up to 1/3 blockage. Grade 2 up to 2/3 blockage, and grade 3 up to 3/3, or the entire up to 100% blockage. And you can treat exostoses conservatively to start with regular debridements to prevent your recurrent acute otitis externas, water trapping, and prevent any perforations or development of canal Klesatomas by doing the debridements. And in that patient that I mentioned before, he had an exostosis and had a hidden Klesatoma that I had him get a CT scan, but then it was done inappropriately, and he actually brought the wrong CD. So then I couldn't tell until the surgery that he actually had a Klesatoma and had to do a mastoidectomy, and it would have been nice to know that beforehand. So in general, I make it my practice to always get a pre-op CT for patients with exostoses before I do surgery. And you can conservatively treat by preventing water getting in there. So a combination of wetsuit hoods plus your silicone waterproof earplugs, aquanauts, what have you. Patients have been shown in one study to be associated with otosclerosis 1/3 of the time. And so the House Ear Institute, they are comfortable with going ahead and doing the exostoses surgery, canaloplasty, and the stapenotomy at the same time. Personally, I like to stage it. So surgery is indicated, according to some authors, if there's greater than 70% occlusion, if there's symptomatic with conductive hearing loss, recurrent otitis, if they have chronic accumulation of debris and water. Surgery obviously puts the facial nerve at risk, which can travel lateral, especially can travel actually lateral to the annulus, and you can be misled if you're drilling too much posteriorly of the posterior canal in the medial part. You risk injuring the tympanic membrane and the TMJ. Some people advocate avoiding the drill when possible because of the known acoustic trauma from drilling, and instead use microosteotomes. So I prefer to use the drill to create the groove. So drill at the base of the exostoses to create a groove for these micro chisels to fit into, and then knock off each piece that way. So it's a little bit of a hybrid. And you want to preserve the skin as much as possible to help with your post-operative healing. Otherwise, you may need to get some fascia or do a split thickness skin graft. And you want to be cognizant of the tympanic membrane, especially at that anterior angle where the exostoses tend to really push up against the TM. And you can protect the TM with silastic, with foil. You also want to always fracture the bone away from the TM to prevent perforation, and probably be a little bit more conservative with how much you're removing at the annulus, at the anterior annulus. This can be done via transcanal and oral post-circular approach. I prefer to do it transcanal. It is challenging and it requires a combination of experience and skill. So this is an example of an oral polyp and or granulation tissue at the bony cartilaginous junction. There are many different causes, including malignant otitis externa, even just an acute otitis externa, chronic otitis externa, malignancy. Here's some other causes: just having an ear tube, chronic otitis media, Klesatoma with perforation, glomus tumor adenomas, meningiomas, capillary hemangiomas, melanoma, squamous carcinoma, parotid tumor. You can even have a pseudoaneurysm of an internal carotid artery, which has been reported in a handful of cases. There's even cases of a high-riding dehiscent jugular bulb that's also lateral and coming into the ear canal. Tuberculosis, encephalocele, and yeah, so there are a lot of things to think about when seeing an oral polyp. Osteonecrosis of the temporal bone also very important. It's rare, but it's important to recognize it can masquerade as a patient with recurrent acute otitis externa. But if you do a thorough cleaning, then you would see exposed necrotic bone of the canal. And it can be caused by radiation or oral bisphosphonates. The ear canal is predisposed to this osteonecrosis, thought to be because of the thin skin and the very tenuous vascular supply to the ear canal bone. The symptoms may present years later after radiation with nonspecific pain, drainage, hearing loss. Failure to address this can cause progression of the osteonecrosis, osteomyelitis, which can lead to cranial neuropathy and potentially even lethal intracranial complications. If it's limited to the ear canal, then you can manage conservatively by debriding, removing any necrotic bone, using hydrogen peroxide, topical drops, and also if it becomes more severe, then you may need to do a radical mastoidectomy, subtotal petrosectomy, lateral temporal bone resection. Okay, so since we are running out of time, I was just going to talk about the sort of the summary. I'd like to jump to the summary slide here. So again, the takeaway from this lecture is that acute otitis externa can really have a wide differential, and we want to just get you thinking about all these possibilities. You can have overlap with just an acute otitis media because you can have your associated bullous Merigitis. And to confirm that, you want to check if there's any middle ear effusion. If you can't tell, then Typonometry or Pneumatic Otoscopy is my favorite thing to do. It's a pruning otoscope where you have a bulb and you have to get a good seal. But you can also kind of jerry-rig a regular speculum by putting different like rubber fittings on it to get a good air seal. If you don't have access to a tympanometer. Chronic otitis externa predisposes to recurrent acute otitis externa, and rarely this can lead to acquired ear canal stenosis. We've talked about treatments with steroids, possibly adding some nystatin. And chronic otitis media with perforation, you want to be thinking about, is there a Klesatoma present? The perforation can confound things because the infection can travel between the middle ear space and the ear canal. Malignant otitis externa usually starts out as acute otitis externa in your vulnerable patient population, and this MOE can be confused with malignancy or osteonecrosis. We've talked at length about the diagnosis and the management. Periclinitis can be secondary to an acute otitis externa, and the canal can end up being swollen shut. You might think, oh, this is an acute otitis externa, but it may just be a periclinitis. Also be thinking about relapsing polychondritis if you have any suspicion. Miringitis, we've talked about. You can have granular or chronic miringitis that can lead to canal stenosis, and you want to really debride and use topical treatment. Otomycosis can be coexistent with chronic otitis externa. Malignancy, we talked about, can commonly be misdiagnosed as acute otitis externa initially. We talked about Osteonecrosis, and then also allergic contact dermatitis. If they have these little streaks where the drops are contacting, and start thinking about, well, maybe is it the aminoglycosides or actually the steroid drops that are prolonging this cycle of contact dermatitis. Okay, so this is a list of about 100 references that I used to help write the chapter. And any questions?
Ray, thank you for the very comprehensive lecture. There was in the chat, there was a question that says, do you have any tips on how to get boric acid powder into the ear canal?
Yeah, so we have these insufflators. It's called the Sheehy Insulator. So Sheehy, like the ear surgeons, Sheehy. But it's costs like $70 online to get it. I don't have any other ideas for an easier way to get a hold of that. But even your like pneumatic insufflator, things that are attached to your otoscopes, you can put a little bit into the speculum and then puff it in that way. But yeah, it's essentially, and you can also, even if you have like an air blowing mechanism in your clinic office, you can blow the powder around. That's what I do with boric acid.
What about using like a 1 cc syringe and cutting off the sharp point of the needle and just blowing it in with the syringe? That's probably
I think that's a great idea. Yeah, that would totally work.
Okay, and then the next question is, what can we use for acidification of the ear canal?
Yeah, so boric acid certainly, and that's it also helps dry things out. If you want to do irrigation, you can do a half-strength vinegar, but in general, you want to make sure the patients are drying out their ears afterwards by either just letting it drain out and not covering it, and or using a blow dryer on a no heat setting or fan or something to really dry out that irrigation that you just put in. But definitely half-strength vinegar, just your regular distilled white vinegar. That's great for a lot of these chronic otitis externa, chronic granular miringitis, otomycosis, for mucosal disease. If patients have had a mastoid cavity and it's draining because of persistent mucosal disease, and also you can use more concentrated trichloroacetic acid in the clinic, applied to like a little cotton tip or something, just to really focally treat the mucosal disease. That's what I do for acidification.
Okay, great. Does anybody have any further questions? Either put them in chat or open up your microphone and feel free to ask Ray. At this point, Ray, I think those are the two questions that were given. Again, thank you very much for your time. We'll post this on the YouTube channel, and if anybody has further questions, please feel free to just put them on the global web chat room on WhatsApp, and we'll make sure that Ray gets them addressed to him and you get the answer. Okay? So Ray, thank you.
Perfect. Thank you so much for inviting me, and I look forward to the future and coming back to give a talk on maybe another topic. So.
Very good. Thank you, Ray. Thank you, everybody, for joining, and this ends today's lecture.
Thank you.